Thank you. So I'm just going to present some data from the UK on the spectrum of cases that we see related to SCN2A mutations. So this represents the really the output from the Great Ormond Street early onset epilepsy diagnostic next generation sequencing panels. This represents the cases that were referred to it and that came out with an SCN2A mutation. We've previously published what we found with this panel, and SCN2A has been our number one hit from the early onset panel and appears to be the most commonly mutated gene in the early onset epilepsies in this population. So from the cases that were referred, essentially we identified 21 mutations. 19 of these were identified by the panel, and 2 of these were also identified on research-based whole exome sequencing. So as you can see, the majority of these, in fact the vast majority, are missense mutations, but we did identify one truncating mutation, which, as you'll see, was associated with a later onset epileptic encephalopathy, as we've heard earlier today in the talks. What we also saw was several recurrent mutations, but the majority of the mutations were novel. We saw that most of the mutations were de novo, and this, I think, reflects the phenotype of the patients that we're seeing. But we did identify one paternally inherited mutation in a child with an early onset, in fact, an onset under 3 months of age, of an epileptic encephalopathy. And this mutation has been subsequently identified in one case reported in ClinVar, although the details are slightly lacking. What we did notice was that the majority of the patients that were being tested on our panel and being found to have SCN2A mutations really were in that under 3 month neonatal encephalopathy group that we heard about today. So I'll just talk a bit more in detail about some of the mutations. Apologies, this is a bit busy. But essentially, we saw that the majority of the babies that we were seeing come up with mutations on the panel had very early onset, neonatal onset seizures. We saw that most of these babies, although they had this very neonatal onset, did not fit easily into one of the known electroclinical syndromes. So although we had a couple of diagnoses of one of Ohtahara and one of migrating focal seizures, what we saw was that many babies would have some features of a syndrome but not all. So this baby here had some burst suppression on early EEG, but had some clonic seizures and not typical tonic seizures of Ohtahara syndrome. And in general, these babies had a variety of seizures, including prominent focal seizures. What we did also see in this population was that, as we've heard extensively throughout the meeting, sodium channel blockers were found to be effective in many of the patients. What I should say is that some of these cases are from 4 or 5 years ago now, where we weren't perhaps aware of the importance of early use of sodium channel blockers in neonatal seizures. So many of these patients didn't receive treatment with sodium channel blockers until much later in the first year of life. So it'd be interesting to know whether their fairly severe outcome in terms of development would have been the same if they'd had earlier treatment. What I would like to point out is that, as we've heard, movement disorders are common in SCN2A, particularly in the under 3 month onset of seizures. And we found in this study, and also in a subsequent ongoing study which has been undertaken by Dr. Kathleen Gorman from our group, that movement disorders are occurring in about 25% of the patients with a neonatal epileptic encephalopathy. And what we're finding is, although that we do see dyskinesias, there's more a dystonic phenotype is more common. And what's interesting is that often this comes in the second year of life after the seizures, which may have responded to carbamazepine or have evolved because of the natural history, have become less of a problem. So it's interesting to understand why this presents in the second year of life, whereas the epilepsy is of such an early onset. So I've essentially presented to you a profile of the patients that we diagnosed with SCN2 mutations on the GOSH panel. And what we find is that we are identifying these mutations in babies with very early onset seizures, which probably reflects some ascertainment bias in the patients that get referred for our panel. And I think it'll be interesting to see how the developmental profile and outcome of these patients evolves as they have earlier treatment with carbamazepine. Thanks.